Okay, so welcome everybody. It's for me a great pleasure to introduce Professor Pia Sormani. I'm not going to go through her CV because she's going to do it herself. And she's going to tell us finally everything I always wanted to know about how to work usefully with a medical doctor. So Pia, please.
So thank you very much. It's a great pleasure for me to be here. I'm a bit nervous speaking in front of so many mathematicians and informaticians. You know, I'm used to talk to medical doctors, so please excuse me if I'm going to be sometimes too simple. So I have the answer to the question that was in the title. I think that, you know, I have a degree in physics and I started working with medical doctors, and I immediately realized how difficult it is interacting with them. And I think that these three are three requirements that we need to produce something useful in the interaction. The first, it seems to be trivial, but it's not. The flow of the problem must be in the direction that goes from the medical doctor to the mathematician. I would talk about mathematicians, but I intend the scientific word. The doctor has a problem to solve and search for an algorithm, for an help to solving that, and not vice versa. You know, working with doctors very often happened to me to have mathematicians telling me, well, I have a very fancy algorithm. Do you have a medical problem to apply it? So this does not work. Maybe you can find a medical problem, then you can try to apply your algorithm, but it's difficult to produce anything useful. The second requirement is that the mathematician must fully understand the medical problem. So if you start working in oncology, please study something about oncology and really understand the medical issue, because medicine is not like mathematics. There are very subtle things that can have a very large importance. And finally, do simple things. In the field of medicine, all the mathematical stuff that has been used is very simple. The Cox model, that is the model used for analyzing survival events in all the medical fields, is a very simple model. It's not always the best model, but it's the one who had a lot of success because it was simple. So this is my CV, very short, to show you how international it was. I was born in Genoa, I was trained in Genoa, I was married in Genoa, and I'm now employed at the University of Genoa. But you know, it was not by chance. I really loved my city, and I tried to do everything staying here. Then, I spent a lot of time abroad, but my training and my life was always based here. And this is my professional CV. I got a degree in physics here in the department next to this one. And I had a degree in biophysics with Professor Vincentore. I was working also with Alessandro many years ago. And then I became a professor of biostatistics, of statistics in medicine, working in the medical school. And the link between these two different careers, that I married a medical doctor, it has an impact on my choices, for sure. And also, that's also one reason why I'm able to interact with medical doctors. So, in this talk, I will tell you about some issues we have in medical research that are typical to medical research, that for us are trivial, but maybe for you are not. And I hope to suggest to you some place when you can have a role in collaborating with medical doctors. So in medical research, we have ethical problems, and this is not the case in other scientific fields. Theoretically, we cannot replicate experiments because the unit of the experiment is a human being. So once you have demonstrated with an experiment that is a clinical trial that drug A works better than drug B, you cannot replicate it because you must give all the patients the best drug. So this is, of course, is an issue, and this is why, the experimental setting in medicine is particularly challenging. In medicine, it's very difficult to establish cause-effect relationship because the biology of the human subject is very complex. There are many factors interacting, so the only thing we are able to discover usually is a correlation between two events, but we are not always sure that one event is the cause of the others. So there's the problem of bias and confounded that I will touch briefly during the presentation. And then a big issue is the interaction with clinicians. Many of them think to be God, so this is it creates a lot of problem in trying to change their mind in specific field. And I'm saying that because I think this is very typical of medical doctors. I never found this attitude in other fields. I mean, maybe rarely, but. So, some basics of clinical research. I will talk very briefly about the evidence-based medicine, about the randomized clinical trial, and the phases of clinical research. Evidence-based medicine. In medicine, there has been an evolution from the past in how the medical doctor is seen and how the relationship has changed. In the past, in a very far past, the doctor was the magician. In the tribal culture, the doctor is the wizard. He's in contact with God, and he can cure patients because he interacts with God. In the last century, the doctor is an expert who knows how our body works in a deterministic framework. There's a disease, I understand how the body works, how the disease affects the body, I can cure the disease with the medicine, and if the medicine works, the patient is cured, and everything is in this deterministic way. Now, the doctor is seen as an expert who is able to run scientific experiments to understand what is the correct procedure to apply. The field of medicine is no more a deterministic framework, but is a chaotic framework in which the correct procedure to apply is a probabilistic procedure, and in which very little can be said on what happens at the single patient level. So this is the evolution of medicine to evidence-based medicine. In the past, the disease evolution in a single patient was thought to be determined by the therapy, and the appropriateness of a therapy in a patient can be judged by the outcome. So the outcome of a disease can be the merit or fault of the doctor, and the good doctor is one with many successes. Now the vision has completely changed. We learned that the disease evolution is not predictable in the single patients, unless with some probability curves with large margin of variability. It is not possible to say if the treatment has been useful, unuseful, or even detrimental in the single subject. I can give you an example. An old man, 74 years old, who takes vitamins to prevent cancer, but who smokes, at 74 years developed lung cancer. Were vitamins protective? Well, we can say yes, because he developed lung cancer when he was 74. He is a strong smoker, so without vitamins, maybe he would have cancer when he were 40. Or we can say, well, not all the smokers develop lung cancer, so he took vitamins and he had lung cancer anyway, so they didn't work. We don't know. In the single patient, we cannot conclude anything. It is also not possible to predict the effect of a therapy from physiopathological mechanism. And of course, it is not possible to establish whether the doctor did the right thing from the outcome. Otherwise, oncologists would be all very bad doctors. So the only way to study if a drug works, or anyway, to keep conclusion on a therapy in medicine, is to run scientific experiments, run on very large number of patients, and to obtain average effect that will tell us if the drug is working or not on the average. So this experiment will tell us if we should use this drug in this specific disease, but we'll never know if for that specific patient the drug has been working. So the gold standard for clinical research is what we call the randomized controlled trial. The randomized controlled trial is an experiment in which we have two groups of patients. So a group of patients that is treated with the treatment that we want to test. Think to the vaccine trials. All the vaccine trials that we have heard about, for sure, in these days, they have a treatment group, so patients who are vaccinated, but also a control arm. So all the clinical trials must be controlled. And the control arm is an arm of patients that are enrolled together with the experimental arm and that are untreated or treated with a placebo. And the second characteristic of the randomized controlled trial is randomization. Randomization means that there's a random process assigning patients to the two arms of the trial. This can protect from confounding effects, and I will try to tell you what these confounding effects are. Well, when I started working in the medical field, something that I asked to my colleagues is, why not to use historical control? Because enrolling a control arm is very costly and also expose some patients to a placebo. So, I mean, it's something that is not optimal from the ethical point of view. I mean, if I have a new chemotherapy to test this chemotherapeutic agent, why I cannot use a control of patients who were in the past, who were not treated with this new agent? So this is the issue of historical control. And the Will-Rogers phenomenon is one of the statistical paradox that preclude the use of historical control. Will-Rogers was a comedian, a US comedian. He was very famous in the US. He's a sort of Pippo Baudo in America. He lived at the beginning of the 1990s, and he was very famous for his quotes. And the quotes that gave the name of the paradox, Will-Rogers from Oklahoma, he said, when the Okies left Oklahoma and moved to California, they raised the average intelligence of both states. The Okies were the poor people who, during the Depression in the early 90s, migrated to California. And they were thought to be the worst part of the population in Oklahoma. But people in California are thought to be the more stupid people in the US. So even if you take out the most stupid part of Oklahoma and you put them in California, you increase the average intelligence levels of both states. This is a paradox, because the average intelligence levels of the overall population is preserved, but just moving one subgroup from the other increase the average of both the groups. How this applies to medicine? This was a very famous paper published in the New England Journal of Medicine by Feinstein, that was a statistician, and he demonstrated that the prognostic improvement we observed in cancer from the 60s to the 90s is just because of a Will-Rogers phenomenon. Let's see this example. Let's suppose that we have lung cancer, and we know that metastatic lung cancer has a shorter survival expectation than localized lung cancer. Let's say 1 to 6 months for metastatic, 6 months to 2 years for localized. But the classification of metastatic and localized is according to a diagnosis in the 70s, when just X-ray was available. In the 90s, we had the CT scanners, so we are able to see very small metastases. So, I mean, even if the overall prognosis is the same, by simply moving one subgroup of localized tumors to the metastatic group, because we see small metastases, we improve the survival of the localized, and we improve the survival of the metastatic. So, I mean, it's not, I mean, even if this improvement was not so big, there were many papers saying, wow, we are much better in curing lung cancer because the survival improved both for localized and for the metastatic. And this is just to show you something that I did, and to show you how simple it was. So I started working in oncology, where the Will-Rogers phenomenon was well known. And this is one of the first good papers that I published on the Annals of Neurology, showing that the Will-Rogers phenomenon is there also in multiple sclerosis. I work mainly with neurologists in the multiple sclerosis field. You see that the graph is very simple. It represents the prognosis of patients classified in two groups of multiple sclerosis. The CIS are those at the onset, clinically isolated syndromes, those who had just a clinical attack. And for having the diagnosis, you need 2 relapses. And you see, the gray bar is the prognosis in the CIS and MS subgroup according to the old diagnostic criteria. The prognosis is the probability to reach a high disability level over time. Applying the new diagnostic criteria that are based also on MRI, so the same group of patients classified as CIS or MS according to the newer criteria, you see that the prognosis improves in both subgroups. And this is clearly a Will Rogers phenomenon, a different classification, not a different prognosis. And this is why it is so dangerous to compare patients who are diagnosed in a diagnostic category now with patients who were diagnosed in the past, because they were classified in a different way. So we always expect that recent patients are better than older patients. Another phenomenon that require a control arm is the phenomenon of the regression to the mean. I suppose that you are aware of that. The phenomenon of the regression to the mean precludes us to design the study as a baseline versus treatment. So to follow patients for a period, then treat them and follow them after treatment and compare the 2 periods. And the regression to the mean is the phenomenon where random fluctuation, there are random fluctuation around a mean value. So if you observe a phenomenon at one extreme, at the subsequent observation, it is easier that this phenomenon has regressed to the mean. If I take the blood pressure to all of you, if we found one with a very high blood pressure at the subsequent measurement, it is very likely that the blood pressure goes down. So, you know, when you enroll patients in a trial, usually you take patients who are in an acute phase of the disease. So even without any treatment, there's a high probability that they regress to their mean. And I mean, this is the regression to the mean phenomenon is also the bad luck of sport champions who got the cover of Sport Illustrated one year, that the years after they go worst. It's simply because, I mean, if a champion has very special performances one year, it's mostly a matter of luck. So this was a presentation given by a very funny statistician who said that also regression to the mean is a very useful phenomenon, because imagine a world without a regression to the mean. Very, very small people are expected to have children that are taller than them, and the opposite is true for very tall people. If this wouldn't be the case, after some years, the population of humans would be made of very small people and very tall. And of course, this is something that is very easy, but also the placebo effect is a neglectable effect. I mean, the placebo effect is a true effect. Treated people feel better than people who are not treated. This is a study we did with a neurological clinic on an herbal drug for neuropathic pain. Pain, insomnia are the most dangerous outcomes. And the company producing the drug asked us to give the drug, to follow the patients for their neuropathic pain for a period and then treat them. So also regression to the mean problems, but you see that the neuropathic pain dropped down during treatment. But when we ran a similar experiment with the placebo group, you see that the same effect was there also on placebo. So this herbal drug was probably a very good placebo. But I mean, it's a problem of cost. You don't need to put the herbs into a placebo to make it a placebo. A few words about randomization. You know, randomization is sort of is the most important aspect of a good experiment, and it's also sometimes hard to run and to obtain, because just consider that you must tell to a patient that if he entered the trial, he will have 50% of probability to receive a placebo. And they must accept that. So, I mean, you can understand that can be sometimes it can be challenging, because many patients want to enter a trial because they want to receive the new drug. But the problem is that it's quite impossible to create two groups of patients whose characteristics are well balanced. And these characteristics, if they are not balanced, can impact the prognosis and can obscure the real effect of the drug. Here there's the story, a true story that was published in a biological journal, in which the experimenter wanted to test a pollutant on these small fishes called guppies. And they had 100 guppies, and they allocated the guppies randomly in 5 tanks. But in the end, they discovered that there was a drop in survival from the fifth to the first tank, in the sense that in the fifth tank, the survival was much higher than in the first, despite the pollutant concentration. The problem here it was that the selection of guppies was not fully random. They took the first 20 that were the less lively, and they were those who died before. So, you know, also a randomization process that seems to be random needs to be really random to be effective. For us, confounding factors are another challenging issue we have to fight. The confounding factors are factors that are linked to the variable we are studying and that are linked also to the outcome we are studying, and they can confound the relationship. This is a simple example. This is a paper that was published in the American Journal of Cardiology, a very good journal. And in this study, the researchers studied the association between having a pet on the outcome of patients who had a myocardial infarction. And they discovered that myocardial infarction survivors had better post-infarction heart performances if they have a dog, but not a cat. So the conclusion was, well, the dog, is more empathic, and you love your dog more than the cat, and this love makes your heart better. Of course, in this study, there's a confounding effect that is physical activity. Who has a dog is constrained to much more physical activity. So, in this case, if a confounding factor is known, from the statistical point of view, you can correct for that. You should, of course, analyze the outcome in patients who have a dog, adjusting for physical activity. And just to show you how it works, adjusting for this confounding factor, this is something we are very used to do, that is multivariate analysis. That is a statistical model in which we adjust for all the possible confounding factors. This is our study that will be published in 3 days on vaccine in people with MS. And you see, our aim was to discover whether there are some therapies reducing the antibody levels in patients with MS. And we discovered that there are 3 drugs, fingolimod, ocrelizumab, and rituximab, who, these are multiplicative factors on the antibody levels, who really decreased the possibility to develop antibodies. But before concluding that, we had to adjust for all the other factors that are age, the level of disability of the patients, because this is not a randomized study, so the drugs are given according to the patient profile. So all the patients are expected to take a different drug than younger patients. So you have to adjust for all these confounding factors. This is what we always do. The multivariate analysis uses linear models or log linear models. So it's something very, very simple. I'm sure that with machine learning, you can run something even non-linear and much more sophisticated than what we do every day. Well, the bias is another factor affecting our ability to discover through relationship. Is much worse than confounding, because confounding can be adjusted for if we are able to measure that. But bias is a systematic effect, the defect we had in the selection of our sample. This is a very famous example that is related to the survivorship bias that happened during the Second World War. The American had a lot of loss due to the German contraerea, okay, and they decided to run a procedure to protect the planes from the Germans. So it was not possible to reinforce the full airplane because it would be too heavy. So they decided to run a study to decide whether to reinforce the plane. And so they ran a formal analysis, and they tried to select the area that were most frequently hit by Germans. And they discovered these 4 areas. Then they were suggested by mathematicians that they should have reinforced not these areas, but exactly those that were not represented here, because this is a survivorship bias. This sample is the sample of airplanes that was able to come back. All the airplanes that disappeared are not represented in this sample. And so the correct procedure was to reinforce exactly the area that were never hit. And this was applied, and the success was great. They doubled the percentage of airplanes that were able to come back during the Second World War. So, a few words about the phases of clinical research, because this is something, again, that maybe you have heard during the pandemic, because, a lot of words has been spent for phase 2 studies, phase 3 studies. But anyway, clinical research is very costly and has ethical implications. So it has been divided in 4 phases to minimize the number of patients exposed to new drugs and also to the risk of new drugs, and also to minimize the cost. Phase 1 is just devoted to understand if the drug is toxic. We are talking about clinical research. So we have finished all the animal experiments, and we are giving the drug for the first time to humans. So the phase 1 is just to discover if the human can take the drug. The phase 2 is to determine the activity. Phase 2 studies are more studied to see whether the drug works somehow, while the phase 3 is to determine efficacy. And with efficacy, we mean something with an impact on the quality of life of patients. So the drug can work, modifying some vital parameters, but it can be approved on the market always if it changes the life of patients taking it. And the phase 4 is post-marketing studies, more related to pharmacoeconomic. So what determines the phase of, I will concentrate on phase 2 and phase 3, because phase 1 is just toxicity. But let's suppose we can go in phase 2. What determines the phase of the research is the endpoint. So the variables on which we will measure the effect of the drug. And usually activity endpoints are very easy endpoint, variable that can be measured very quickly on a small number of patients. For example, in MS, in multiple sclerosis, the typical activity endpoint is the number of lesions that are detectable at MRI in the brain of patients with MS. A lesion, an active lesion from when it develops to when it is cured lasts 1 month. So, if you run a 6-month trial, you can compare 2 groups of patients and check whether the treated group has less lesion than the untreated group. But we cannot approve a drug if it simply decreases the number of lesions. We must go in phase 3 and demonstrate that the drug works on disability progression for MS, because MS is not a lethal disease, so it accumulates disability. But in oncology, we must approve the drug if it has an impact on survival. In oncology, the classical phase 2 endpoint is the tumor response, the reduction of the tumor mass. But the patient doesn't care if the tumor reduces mass and he survived the same period. So, and this is just for showing you another field in which I've been working a lot, that is the validation of surrogate endpoints. Surrogate endpoints are phase 2 endpoints that has been demonstrated to predict the effect on phase 3 endpoint. So a modification of the phase 2 endpoint translate in a modification of the phase 3. So you don't need to go in phase 3. The result on the phase 2 is enough. I started working in oncology where tumor response needed to be validated as a surrogate marker for survival. The issue was that it was clear that people with a reduced tumor mass survive longer than people with a big tumor mass. So the tumor mass is correlated to survival. But the point is that probably those who reduce their tumor mass because of the treatment, do they really have a benefit in terms of survival, or simply they are those who would have survived the most? I mean, the possibility to reduce the tumor mass is simply a prognostic factor indicating those with a longer survival anyway, independently from treatment, or is the reduction of the tumor mass that cause a survival benefit? So this is what we had to demonstrate to validate tumor response as a surrogate endpoint for survival. And consider that this was true for metastatic breast cancer, but it cannot be true for colon cancer and for another drug with a different mechanism of action. So this must be demonstrated for every drug and every disease class. Working in MS, this is just for telling you how the field of medicine are completely disconnected. The theory of surrogate endpoints was well known in oncology. When I started working in MS, and I saw that clinicians were studying MS, studying the lesion in the brain, my first question was, are MRI lesions a validated surrogate for clinical outcomes? And the answer was, surrogate what? So in MS, we had to restart again to validate MRI markers as surrogate from scratch. Okay, here is a list of papers in which we try to clarify this issue, but just to show you how simple things works better. These two papers, Annals of Neurology in 2009 and Lancet Neurology in 2013, are maybe the best papers I ever wrote, and they are incredibly stupid. But they are those who validated, that clinicians accepted as a validation of MRI lesions as a surrogate for relapses in MS. This is a simple correlation. I took all the clinical trial testing the different drugs in MS, in which it was reported an effect on MRI lesions and on relapses. And I put them into a correlation. So I demonstrated that the larger the reduction in MRI lesion, the larger the reduction in relapses. And then I replicated on an independent set of trial years later. So, there's nothing complicated here. It's just a simple linear regression, just weighted for the size of the trial, but it's really a very simple analysis. So, concluding, I want to show you just something we are working on now, and that it's very complex, and it's in what we call the challenge of personalized medicine in MS, in my case, but anyway, to try to define responders to therapy. The problem, as I told you at the beginning, is that when we run a clinical trial, we obtain an average effect. So in MS, for example, we say, well, the drug works because in the treatment group, there is 30% less relapses than in the placebo group. So the effect of the drug is to reduce relapses by 30%. You have heard that vaccines reduce the probability to get a severe COVID by 94%. So this is an average effect. We never know for each patient if the drug has worked or not. In this case, all the patients have a number of relapses, and you don't know if for him or for her the treatment has worked. This is known at the group level. So it's, by definition, we know that everything is very heterogeneous in medicine. So there will be some patients who have received a very high benefit from the drug, and some of them who have received no benefit. The key point is to try to find biomarkers or clinical variables, so some patient's characteristic at baseline, at the beginning, that can tell you if the patient is one responding or not responding. And this is not possible to be done mathematically because the single patient is or treated or untreated. So, I mean, you just can reach this information at group level. So a very simple approach is what we call subgroup analysis. You have a 30% reduction on relapses on the overall population. Thank you. And for example, you separate male and females, and you check whether the treatment effect is higher in males and in females. You see in this very small graph, for example, it is visible that separating younger and older, the treatment effect is much higher in younger. So from this subgroup analysis, you obtain some more personalized approach, because this drug is more indicated for younger people. What we try to do is to develop a combination of baseline variables, a combination that is a linear combination, always very, very trivial, that is able to predict a differential treatment effect. So every patient can be characterized by this score, made up of a combination of sex, age, disability, and whatever, that will tell you which is the expected effect from that drug. And I will show you this is a nice story, because I mean, there are some implications also of interaction with pharma companies. You know, pharma companies don't like to see responders and non-responders. Because if they had their drug approved for all the patients, they don't want to know the characteristic of non-responders, because this limits their market. So, I mean, we are having a very hard time in convincing them to give us the data to validate this kind of modeling. And this story was run on a drug that is called laquinimod. Laquinimod was not approved for the treatment of MS. So the program failed, so the company gave us the data to run our analysis because they're not interested anymore. And you see, this is the story of laquinimod. They ran 2 clinical trials, Allegro and Bravo. The figure you see are the typical survival curves representing the probability to be free from a progression over time. So the curves start from 100%, and as long as time passed, every patient that progressed, the curve goes down, and you compare the 2 treatment arms. So you see that the probability, the red is the laquinimod and the blue is the placebo. You see that in the Allegro trial, there was some evidence that the drug was working in delaying the probability to progress in the MS patients. And this is summarized by this number, the hazard ratio. The hazard ratio is the ratio between the velocity of progression in the two curves, just to be simple. The p-value 0.01 indicates that this is statistically significant, so it cannot be by chance. It seems this is a true result. In the Bravo study, the second study, the size of effect was the same, hazard ratio 0.6, so a reduction about 35% in the velocity of progression, but the p-value was 0.6. This means that we have a 6% probability that this is a false positive result. So the company decided to run a 3rd clinical trial. It was a bet, because I can't tell you how much it cost running a clinical trial, and they ran the Concerto that was fully negative. You see in the Concerto, no difference between treatment and placebo, and they closed the program. We had this data because we ran some subgroup analysis, and we had the feeling that there were a very heterogeneous response to the treatment. So we ran our statistical modeling. I don't have the time to go in deep how we did it. It's a very heavy procedure of training and testing, but this is a very ideal condition because we had 3 independent trials. So we trained the model on the Allegro, we tested on the Bravo. If the performance was not very good, we came back to the Allegro, we tuned the parameters and back and forth. And then when we got a final model, we tested on the Concerto study. And you see that in the 3 trials, we were able to define a subgroup of patients defined with this score, that made up of age, sex, previous relapses, the size of the brain, and the number of lesions, of active lesions in the brain, combined with different weights. And we choose a cutoff for this score as responders and non-responders. And you see that we are able to find in the responder, the hazard ratio was 0.38 in the Allegro. 0.38 means that the probability to have a disability is reduced by 60%, a huge effect. Why 1.3 is nothing, I mean, in the non-responders. It was perfectly replicated in the Bravo, and it was also replicated in the Concerto. What happened is that in the Concerto, the proportion of responders was much lower than in the Allegro and Bravo, so they, at the overall group level, they were not able to see any effect. But also in the Concerto, the same subgroup seems to be a very high benefit from this drug. So, I mean, this was just an exercise because laquinimod was not approved. Okay, these are the survival curves in responders and non-responders. And this is something that we are still doing. This is a study comparing glatiramer acetate and interferon, that are two drugs widely used in MS and are given with the same indication. So there are no criteria to decide whether to treat a patient with interferon or glatiramer acetate. We did the same exercise using, in this case, a very large international database with propensity score matching to simulate randomization. And we were able to find a score indicating who are those with the larger benefit from glatiramer acetate and those with the larger benefit from interferon. I mean, that is something that is useful at the clinical ground. Clinician can use this simple score, I don't know if I have, no, that again is a linear score, to decide whether to treat the patient with one drug or the other. So I'm concluding this is my group of neurologists. I have very large number of young neurologists collaborating in a network, because I was lucky. You see at the, in the middle, the MAST study group. The MAST was an educational initiative started 10 years ago. I was teaching statistics to medical doctors, but to young medical doctors, that they became friends. The network has been created, and now it's a very productive network collaborating on data collection. And all the study we have done of COVID in MS has been done thanks to this network of young people. And I think it's all.
Well, thank you very much for the very nice presentation. And are there questions or remarks from the audience?
I think it's a bit far from what you do.
It was very interesting.
Yeah, you know.
Giovanni.
Giovanni. No, I'm saying that as a statistician, I'm a little in the middle between medical doctors and people like you. I had a lot of nice interaction. And I think that there would be a lot of application of what you are doing to the medical field. The issue is to understand each other. It's a very simple regression model. We run two separate models in the placebo and in the treatment group. And it's a multivariate linear regression. So you find the weights in the placebo and the weight in the treatment, and you take the difference. These are the weights of the score. Because the idea is that if a variable, say sex, is not modificating the effect of the drug, you will have the same weight in placebo and in the treatment, so the difference is 0. But if the prognosis for males is very different than the prognosis of females in the treatment and in placebo, you will have a large difference, and this makes. Yeah, it's negative, but if you look at the confidence limits, you see 1.307, 2.25 means nothing. Because, you know, you always must consider the variability of the estimate. So 1.3, yeah, it's a good suggestion. It seems it is dangerous, but in reality, with this confidence limits, this means that it's nothing. Yeah, the weights on the weights were computed on the Allegro. You know, we ran a, this is why we would need you, because we ran a strange procedure because we didn't have a method to select the variables to include in the model. Because we have a lot of baseline variables, and so we didn't have a procedure to select. We tried some univariate, but we didn't. So the idea was to test all the possible combinations. We ran 32,000 models, one with age and sex, one with age, sex, and all the possible combinations. We selected those working on the training set. We tested on the Bravo. We selected those working on the Bravo, and we selected the best on the Bravo. If the best on the Bravo is working good also, we go out on the Concerto and this, I mean, this is the final validation. It's taken away, yeah, it's just, yeah. But you know, this is a simple approach using simple methodology. I'm sure that running some clustering or things like that would be much more effective. And this is very important because, you know, personalized medicine is, you know, in cancer is somehow easier because you had the cancer, you cut it, you examine all the characteristics, you have the genomic profile, biomarkers, and we have a lot of information about the characteristic of the cancer who respond to the different drugs. For multiple sclerosis, I mean, we don't have any indication because it's a very heterogeneous disease. All the patients start and then you don't know where they will go. So also choosing the therapy at the beginning of the disease is very challenging. And it would be very nice to, we have plenty of therapies, so it's really challenging also because, I mean, you have many choices. And it would be great to have indication on how to choose. But you know, it's also, I mean, the interaction with pharma companies is a challenging issue. It absolutely depends on the. Sure. The question is if this is the typical size of clinical trials, so if it depends on other factors. And the answer, it absolutely depends on, first of all, on the outcome you are analyzing, how frequent it is. You know, for vaccination, the trials were lasting 1 month because, I mean, the COVID infection is quick. And in 1 month with a large sample size, you can have, but on the other side, they were very large. For MS, this is the typical duration for MS, assessing progression as the primary outcome. Progression is a pretty rare event. It takes time to be confirmed. So, but 1,000 is the size of clinical trials. Oncology is similar, yeah. You know, with these new immunotherapies, the sample size is smaller because the effects are huge, surprisingly huge, so you need less patients to see them. But yeah, the typical sample size for a phase 3 clinical trial is 1,000 followed for 2 years. That's the story. And the cost of clinical trials has become, $1,000 million. This is the cost for pharma companies of clinical trials. There are so many, so much bureaucracy now. Also, all the privacy issues, all the everything must be done in. You know, at the academic level, it's quite impossible now to run a clinical trials in oncology or in chronic diseases. It's quite impossible for the cost. So, you know, we unfortunately, we need pharma companies to run this kind of studies.
Oops. So we have a question from Lorenzo Rosasco. I don't know why there is this noise. Okay. So he asked that. Sorry. What's the problem? Maybe I have to change something.
Much better.
Maybe now? No. Okay, better. So, so that often you have a probabilistic model, but basically your data are like a sample where you're doing inference. But then in practice, you have a continuous back and forth between modeling and testing, and then can create some dependencies. And so he asks, how do you deal with the problem that your model becomes purely descriptive and not predictive?
Yeah. No, the training and testing was done on 2 trials, and what the validation was on the 3rd trial and was completely separate from the training and testing. So once the procedure has finished, we went out on the 3rd trial. Usually we don't have 3 clinical trials, so usually we split the sample in training and testing, and we run bootstrapping to validate the procedure. Then if the procedure is validated, we apply the procedure on a 3rd sample of subject. You know, of course, these are limiting factors because sample size of clinical trials is limited. So you lose power to see anything if you cut and you split. But it's also true that if you are able to put together 2 or 3 clinical trials, you have the power to see. Also because the effect on the subgroup of responders is usually much higher than the overall effect. You know, this is also important. It's very important in negative trials because in MS we have a phase of the disease that is the progressive phase, in which all the drug has very, very low effect. And from the physiological from the physiopathological point of view, it's hard to understand why the effect is so small, because the drug is working in other phases of the disease. Why it's not working? So one answer to this question is that maybe there are subgroups not responding at all, and some subgroups really having the benefit. So it's crucial to understand, because sometimes we risk to discard the drug because overall the effect is, and maybe it is very beneficial for a subgroup of patients, but it's very hard to identify them. So this is an interesting field of research in which I think that some informatics would be very important.
I also have another question, more about the impact of statistician in medicine. So because you were talking a lot about these surrogate endpoints, also I didn't know, well, this division between phase 2 and phase 3. Mm-hmm. So for what I understood, okay, you need to reach this endpoint in order to progress and to do the phase 3. But in the end, it's the people running the test who are deciding which are the endpoints somehow. There is not like a agency telling, okay, you...
There is an agency. There is absolutely an agency.
Okay, but then if there is an agency, your work is kind of influencing how these endpoints are chosen, so this meta-analysis...
Sure.
Sure.
I can tell you this story. In MS, the only accepted endpoint for approving a drug is disability progression. Is relapse rate, because there are 2 clinical events in MS. The relapses that are neurological events that are pretty frequent for patients, are not so severe because they recover, but anyway, are impacting their quality of life. And the disability progression, that is a very long-term effect. For approving a drug, you need the drug has an effect on reducing the frequency of relapses. But relapses are caused by lesions in the brain. I mean, all the neurologists acknowledge that the relapse is caused by a lesion. So if you reduce the lesions, by definition, you reduce relapses. Also, I mean, we needed to demonstrate that. We published this study showing that larger reduction of lesions translate in a larger reduction of relapses. Anyway, relapses are still required for new drug, because I demonstrated this for drugs, for all drugs, but the new drug can have a completely different mechanism of action. Okay. What we are fighting for is to accept MRI endpoint for trials in children, because the children world is a different world. So you have to retest everything for children, even if it's already approved for adults. But in children, a drug that has been demonstrated to work in adults, whose effect on MRI lesions translates on an effect on relapse in adults, I mean, there's no reason why in children there should be something different. So something that we have achieved that is very relevant, because running trials in children is very difficult, because you should keep these children on scheduled visits. They have, I mean, for them, they must have regular MRI. It's very hard for them to be involved in a clinical trial. And also MS, fortunately, is rare in children. So it's difficult to put together the number to reach an effect on relapses that is much less frequent than MRI lesions that are a lot in the brain. So this is something that we achieved, and this is something practical that we obtained. That's very nice. The most important thing for a mathematician working in the medical field is to do something that is used, that is useful. Because I was telling to Filippo, we have plenty of journals full of fancy statistical models that nobody never used. And, so the difficult thing is to produce something useful with the practical application. And the only way to do that is to talk with clinicians, to work with them, to understand the issue. Because otherwise, it's really difficult to produce something.
Are there any more questions? Okay, so let's thank Pia again.
Thank you.